would you be so kind to give us a couple of words about yourself, your background, and then I will ask you some questions about the electronic health records.
Happy to, and it's great to be a part of this conference. I've met so many innovative people here. I can feel the energy. And I have to say, on a positive note, I haven't heard one negative thing said about health care companies or insurance companies. The last conference I was at with a group of startups, just to give you an idea of these sessions that went before me, I started off by saying, I hope that by the time I'm done speaking, you think of insurance differently. Then I said, no, scratch that. I hope you think of Aetna differently, but think of every other insurance company exactly the same. I think that, what we have in common is really a commitment to innovation. If we look at the challenges facing healthcare, those are going to be solved ultimately through innovation. We're not going to get ourselves out of the cost quality quandary through discounts. And my background as a family physician, I've been working on those problems in one way, shape, or form for the last 30 years. I've spent the last almost 18 years at Aetna. And what led me to Aetna was initially on the health system side, really wanting to migrate to an electronic medical record, which is the topic of our talk, and getting a training course through Oregon Health Science University, informatics, and really starting to understand the value prop associated with EHRs and how we can leverage those value props for driving innovation and health system improvement. So that's ultimately what's led me to where I am now. And I want to just reiterate what I've heard so far throughout the theme of this day is that collaboration is so important. 1 + 1 = 3. That's how we drive synergies. And so really looking forward to an ongoing conversation.
Great, thank you for that answer. Well, the first question is, what impact do EHRs have on insurance providers and healthcare delivery?
Sure. So, it's funny when I think back to my days as a working student, as a medical director and a graduate student at OHSU, one of the things that they talk about was the whole notion of return on investment when it comes to electronic medical records. And if you looked at the return on investment tied strictly from going to a paper-based system to an electronic system, your payback period was roughly, I think, around 25 years. Anybody think any venture funds will get on board with that? But the real opportunity was when you added in decision support, and that's what drove the return on investment. So when you go to an electronic medical record and you integrate decision support, that's when you get a return on investment that's worth talking about. Anybody want to say why you think you get a return on investment when you add on decision support? Why would that affect your return on investment? I've been eating and drinking this stuff for 10 years, so the answer pops up in my mind right away, but just to see if we're on the same page, do we have any brave takers out there? Quality of patient care, and specifically when you talk about quality of care and driving return on investment, yes.
Decisions are made right at the point of care when the physician is deciding on the treatment plan. Why decision support right at that point, you follow the costs.
That's right. And go ahead. You want to add? This is called Guess What I'm Thinking. Go ahead.
Oh, you're saying you reduce the cost?
You do reduce costs, yes.
Avoiding expensive mistakes.
There you go. So it's adverse events that are avoided if you specifically are looking for what saves money. And so you hear a lot of people talk about discounts, and for those even in healthcare, but outside of healthcare as well, you probably buy one get one free. Anybody want to do that with an adverse event? You buy one and we'll get you 2 of them. And I always say when it comes to discounts, I'm considered a pretty cheap guy, and as it turns out, I'm on day 1 of a 6-day road trip or a 5-day road trip. So I cringe every time I get a stain like coffee on a pair of pants or a jacket that may have to be reworn. But when you talk about adverse events avoided, what you're really talking about is it's the heart attack that doesn't happen. It's the stroke that doesn't happen. Anybody want a heart attack at a discount, anyone? I mean, you're really talking about something that's really hard to argue with saving money that way. So if you think about the the proposition I started with, which is if you go to an electronic from a paper system, you have this really long payback period. When I first came on board at Aetna, I came through a subsidiary called Active Health. Probably, I'm sure there's people in the room who are familiar with it, where it's the flagship product was the Care Engine. That essentially got decision support to physicians, drove that ROI, and did it independently of an electronic medical record. Now, and again, I don't want to steal my thunder. I think I'm getting to one of your questions. But when you move to an electronic medical record and you're embedding that decision support, that makes all the difference in the world.
Great. Well, we'll talk about data integration across different platforms.
Yes.
You know, we got Cerner, we have Epic and all that stuff. Are you able to seamlessly integrate EHRs data with insurance claims data in
Yeah.
your organization?
Yeah, great question. So the decision support that we use historically has been driven by claims data. And if you think about claims data for those who are researchers who've done research on large databases like the healthcare utilization project data, 20% of the hospital admissions nationwide is what it represents, extrapolatable to all hospital admissions. A lot of times decisions about quality and research are made based on claims data, right? And so it's not a big leap to say you could also drive quality improvement through claims data, which has historically been what the Care Engine has used. Now there are additional levers, and I think someone commented on this earlier. You can integrate with electronic medical records. We've done that. We do see a return tied to that integration because it makes it more seamless into the workflow. I think that term that Shapiro would say is that we're reducing friction by doing that. But so there is an enhanced ROI, and I can talk more specifically about examples where I've seen that. One of the things also is that we know that medical knowledge has grown very rapidly, right? And genomic data in particular. So in healthcare, it's always hard when you're looking at real world data to say A caused B because probably B, C, D, and E happened all at the same time. But I think there are some reasonable conclusions we can draw. And yes, there is an ROI for electronic medical records through the CVS Minute clinics. Probably everyone in the room knows that we're now owned by CVS. Anybody not know that? I think everybody knows that probably. We use Epic as a electronic medical record in the retail clinics, but there is increasing investment being made on driving that decision support at the point of care, regardless as to the electronic medical record. And I can talk to some specifics as to where that's been beneficial.
Great. Next thing that we'll touch about is with so much sensitive information in the EHR records, okay, how does Aetna handle the HIPAA, privacy compliance, and cybersecurity?
Yeah, absolutely. So that has been a major focus of ours for decades. And what we've seen is really hiring the best minds in IT from outside of the industry to come in. I learned this term during my time, during my first few years at Aetna. Anybody heard the term ethical hack, where you really try to pressure test your system? I thought that was an interesting oxymoron. But you really try to pressure test your system to verify that you don't have vulnerabilities. And what we've seen with our systems and through our partners is that we have been very effective at protecting that electronic data from being hacked. And, we hear about, unfortunately, some really high profile cases that have not happened within our four walls that I'm aware of about data being compromised. But I think it's a challenge. It's something that we remain very focused on, and certainly not one where we want to get content, because that's something. Healthcare data, unfortunately, is a real target for hackers, that they can use it for all kinds of nefarious purposes.
Great. Dr. Washington, do you feel that use of EHRs by Aetna improves decision-making in treatment approvals and authorizations?
Yeah.
In managing claims and designing new health plans? And also, is it beneficial to the patient?
Yeah, so this is one of those situations where I think there's a win-win-win that I've seen through the integration of electronic data. And specifically, you think about oncology, and I think I've talked to a number of people here about the cancer moonshots and how we've seen precision medicine start to grow in oncology, and with that, we've seen better survival times. one of the things that I worked on during my time at Active Health, going back about 15 years ago, was really developing relationships with specialty vendors in the oncology space. There's some that are very well known, like Innovent. Let's see, head nods. Anybody familiar with Innovent or ITA or P4? I'm not seeing any head nods, so maybe not. This may be a little bit dated, but the idea behind these specialty vendors is that what they do is they integrate data from NCCN or National Comprehensive Cancer Network. There's about 500 updates to the guidelines every year. Oncologists have a hard time keeping up, and then there's the genomic information that's layered onto that. And so what we do is through our own system that we link with specialty vendors, not any of the ones I mentioned, by the way, but we're able to look at both genomic information, look at claims data, and do that through an electronic method. And we've seen the wait time for prior auth go from a couple of weeks to a couple hours because it happens in the electronic records real time. Huge investment in dollars, but very worthwhile in terms of quality, outcomes, and member experience. So I think the doc there who mentioned member experience in the previous talk, I think people do like that quite a bit. Of course, I was thinking about the science, the genomics, and how it's so much more leveraged with this. But what people care about is the convenience, being able to get that decision right away.
Well, that's it. Anybody has questions?
What I noticed from frontline workers and clinicians is that sometimes they aren't worried about so much about the protection of the data, but loss of data that they used to write down. Because there's so many drop-down menus and so forth. So do you think there's a role for natural language processing there, and or what other ways can you capture some of these things that are observations that are made that may be subtle, but they may be based on a lot of experience of a clinician who recognizes things early?
Yeah, thank you for that question. I think it's a great question. And so one of the things that we've done with our approaches to decision support, we never have a group of 20 or so doctors and computer scientists in a room by themselves coming up with these decision support modules and then deploying them on patients without very experienced clinical staff involved in that workflow to make sure that there aren't unintended side effects. And so to your point, what we've seen happen in the industry and within our four walls has been the maturation of these tools, so that I think you make an extremely important point. A lot of the documentation, you kind of think as you write, or at least that's how I used to do it when I was in practice. Now what we have is we have dictation systems where the system has embedded intelligence where it can basically create a note of what's been documented, but do it in a way where the extraneous information is removed. And in fact, one system I tested out was not even you having to dictate it, but the note being recorded between the patient and the physician in real time and coming out with a nice printout and with the extraneous things. And I deliberately tried to fool the system. The extraneous things were taken out and were not included in that. So I think we're seeing that. One of the things we have in our system is this whole notion of, you think about people who have experience interacting with folks on the phone, and you want to be able to enhance what they do. And so we have systems that give them prompts if there seems to be communication that's not being received the way it's intended, so that they can adjust and learn in real time. And I think that's really the best of those systems that I've seen, and there are a lot of them, is that they help to make you a better clinician at what you do. Sometimes that does involve workflow modification, but they tend to help augment ultimately what the human being is doing.
Anyone else?
I have a question. My question in regards to access to data.
Yeah.
Especially even if you're I have a startup company, I'm also in academia. Even in academia, accessing healthcare data is very challenging.
Yes, it is.
They have to go through different processes. It takes time, and it's not enough. And you want to collaborate with different institutions to bring more data into the pool, let's say to the world AI solutions. Where do you see this, let's say in the next 5 years or 10 years? Do you think it's going to be easier to access healthcare data? Or is it going to be like we're going to see the same challenges happening right now?
Yeah, so the technology is there, as you know. It's the political, legal, regulatory dynamics that are slowing things down. at the Microsoft office in Chicago, I actually attended a talk by one of the epidemiologists at Microsoft. And one of the things she shared is one of the vendors they partner with is a company called Bumblebee. Does that sound familiar to anybody? But that company basically can take data from an organization, de-identify it, allow it to be used as part of a database for data aggregation, learning, drawing conclusions and inferences. And then when it goes back to the company, re-identify it. So it's in effect allowing multiple companies to contribute to a large database without compromising identification. That kind of solution is ideal. The technology is there. The question becomes all the organizational barriers, proprietary data. And by the way, they can do the same thing. So I work with a lot of proprietary information, a lot of our algorithms. Those are things we don't want to put out there for public consumption. And it can do the same thing with algorithms. It can de-identify the algorithm and re-identify it. So the technology is there. It's just the political will, I guess, would be the way I would say it. And I will say this, I don't know are you familiar with a company called NewDigs, stands for New Paradigms in Drug Development. They're based out of Tufts. They're a think tank, and they bring together multiple organizations, including competitors. So I hate to say it, but I've been in the room with people from some of our competitors, and we've been asked to play nice in the sandbox. But what they effectively do is they create this federated database that allows you to do a lot of the things that I think you'd be interested in with that. So there are formats. Eventually, I think the lines in the sand will shift, and I do think it will get better, but it's going to take a lot of effort. And as you know, in the American healthcare system, we don't have any centralized entity saying you must do this, so it takes time for people to get on board.